but we'll just run through it pretty quickly. So 2 kinds of drains, passive and active. Passive drains are usually a Penrose, which is one like this. There's another picture in a minute. Drains into dressings, but you can't really control how much is coming out of it. You can't measure how much is coming out of it. There's a little bit of an increased risk of infection. Closed drains are things like JP drains, Blake drains, T-tubes, hemovacs, and then chest tubes, and we'll talk about all of those. This is a Malacot. This is another example of an open drain. Here's a Penrose in somebody's bloody hand. So these are just open. They're just draining into things. They're usually removed before the patient leaves. Hemovacs here traditionally are more ortho. I've never seen anybody in my long tenure here use one on one of our services. And then JP drains are probably the most common drain that we use. They have a bulb. You can activate them, put them to suction, or you can just leave them to gravity and let them drain into the bulb. So usually these are sutured in the skin. They offer a, quote, window into the abdomen. You can see what's coming out of them. So take care to maintain inpatient transfers. Don't rip them out accidentally. To remove them, you want to take them off suction, cut the stitch, and pull them out. If you have issues pulling them out or you didn't put it in, ask somebody. Don't just keep pulling on it until something comes out. Just ask somebody. So another kind of drain that we use is an NG tube, which is the one that we use is a sump drain. So it has 2 lumens. This red arrow here is pointing to the second lumen that allows air to circulate. So this part is on suction, and this part allows air to circulate. It basically keeps it from sucking up against the gastric mucosa and creating a trauma. So again, this is a sump or a Salem sump as opposed to like a Levin NG tube. Gastric contents come out of the clear port, air flows into the blue port, keeps it from sucking up against the mucosa, and you set it to low intermittent wall suction. Troubleshooting NG tubes, the filter may be clogged. This is a filter. If they get wet or gross, they can just be replaced. You can flush it. You can inject air and listen over the epigastrium and see if you hear the air in the stomach. You can get an x-ray, make sure it's placed appropriately. You can adjust the placement. Fun things. Another example of a feeding tube or a nasogastric tube is a Dobhoff tube. It's placed down into the stomach or beyond. You can do this just like an NG tube, and you confirm it with a KUB, or you can use the core track. You can put medications down it. You can feed through it. It's made out of a different material. It's softer, smaller diameter, easier for patients to have for longer. If these get clogged, you can try different things. Soda, meat tenderizer, pancreatic, what is it called, pancreolipase? I don't know what clog zapper is, but I assume it's something analogous to those. Another feeding tube that we use is a PEG. This is a good long-term feeding option, generally set to gravity for 6 hours after they're placed, and then you begin tube feeds low and advance is tolerated. They may have a jejunal component or GJ tube. Usually you feed the J limb there. So this is an example of how the PEG is done. You'd really have to watch a video or do one to feel like you knew exactly what happens here, but an EGD is done, and then a wire is taken back up, the PEG is pulled back down through the stomach, and then secured against the abdominal wall. So this is what it looks like secured against the abdominal wall, and this is what it looks like from inside the stomach. Troubleshooting PEGs, you need to note where it is, especially if you're the person post-op checking the patient. They can get too tight post-operatively if the patient starts to swell. If it comes out early, especially in the first 2 weeks, we need to know about it, or whoever placed it at least needs to know about it, because it can allow the gastric wall to fall apart from the abdominal wall, and then you can have gastric contents in the abdomen. Also, if it's too tight, you can get necrosis of the tract, and it can become a bigger hole and a whole big mess. So. This is important. So we place drains intraoperatively, but also IR places drains. Usually they have a bulb similar to a JP drain. They look different, though. This is what they look like. And usually to take them out, you have to cut them. You can't, because this is taut. There's a string through this that's coming out of it, and it holds this little pigtail taut, and so if you keep pulling on it, it'll hurt really bad. So if you cut it, it allows it to be pulled out. Chest tubes, you put a lot of these in on trauma, used for decompression, drainage. Your ideal placement is posterior and apical. You need to make sure that the last drainage hole is within the chest. You can see it on the chest x-ray. And then we do chest tubes, but we also do the little pneumodart pigtails. and they're connected to an evacuation system, which looks like this. It's put on negative 20 millimeters of mercury suction until the pneumothorax resolves, and it's placed water seal and then removed. So speaking of removing these, so to take these out, this is an example of one that's in here. You can see how it's sutured in. It's all about preparation when you're taking these out. So you want to make your dressing before you even do it, and then I partially put it on the patient. I have them take a really deep breath in. I think that's what the Red Book says last time I checked. And then hold it, remove the tube, place your dressing. And then I think the Red Book also says 6 hours. I know some of the attendings will do 4-hour chest x-rays, but you need to follow up on the chest x-ray after you pull one.
Justin, can you explain what your dressing consists of?
Yes. So my dressing is petroleum gauze of some sort, usually Zeroform with 4x4s and silk tape. So it's an occlusive dressing that I usually place like on 3 sides before I even pull it out, and then pull it out and secure it on the bottom. Another fun tube that we use are urinary catheters. There are several different types: Foley, Cadet, straight caths, condom caths. The difference in a Foley and a Cadet is that a Cadet has like a stiff little tip. That's usually going to be your go-to if you can't get a Foley in a man. It's good for patients that have large prostates. Usually these are placed for urinary retention in our cases. This says post-cath. I think they mean 150 cc's post-void. So if they're still holding on to a bunch of urine and they're just getting a little dribble, they may need a Foley. And the nurses have a protocol for placing these, and then we try to get them out as soon as possible in the next 24 to 48 hours if possible. This is an example of a Foley. Here, this would be like a little bend if it was a Cadet. So, Jillian, I'll talk to you about lines.
Okay. So this is a super common procedure we do. You get a lot of phone calls about access. It's important to know why you need to put a line in. So you have to, instead of just saying somebody told me they needed a line, you need to look at them and figure out what the indication is. Do they need parenteral nutrition? Or is it for monitoring? Are they being resuscitated? Do they need it for dialysis? Is their potassium really high and they need potassium taken off? Is it for plasmapheresis or chemotherapeutics? Sometimes it's also just for poor venous access. They cannot get sticks on people who frequently have to have them, who need blood sampling or frequent IV medications. Contraindications, if they have adequate access and you can't figure out a reason why they would need it, it's important to figure out the reason they need it. Other things, infection can be a contraindication depending on the type you're putting in. So we'll talk about that. So they have a bunch of different devices. We typically use VASCAS, PermCAS. Dr. Dartle sometimes uses Grandrounds. We put in a lot of Portacas, a lot of triple lumens, and a Cordis, a double lumen, in the trauma bay. So kind of our short-term double lumen, you'll put those in the trauma bay a lot of times, and then triple lumens, and then also quad lumens as well if you have a lot of different pressors and things going on in the ICU. And then, of course, we have VASCAS as well for dialysis. So the longer-term ones that we put in are typically like the perm catheters on vascular. You'll see this. We do this in the OR. So you'll see those. It's just a tunneled central line, essentially, that goes under their skin. I'll show you a picture here. It looks like this. So this is the cuff that goes under the skin. Essentially, you stick, the IJ, and then you have to tunnel the catheter down through their chest, and then you basically put the cuff under the skin. It helps prevent infection, and they can leave the hospital with this. Patients cannot leave the hospital with a VASCAth in them. Okay, so if they have a VASCAth, they're still going to need dialysis for a while. They're going to need a PermCath. And then there are the longer-term ones, which you also put in the OR. You'll see a lot of port cases as an intern. They're fun little cases. Essentially, you put them in the same way as a central line, but they have this little device here that goes under the skin. So you tunnel, you create a little pocket for it. You make sure it flushes and works, and you kind of sew it back up under the skin. So when you're going to go do these, you have to talk to your patient or a family member if that's who's there to consent. So you need to know the complications, one, so that you can look for those when you're doing it, but also so you can explain it to them adequately so that they know what you're doing, because everything we do has consequences to it, and there are some real possible complications. So you're going to want to talk to them about bleeding. That's pretty obvious. You're sticking a vein, but there's an artery right next to it. It's important to know it goes in the vein and not the artery, because you don't want to dilate up. It's kind of okay to stick the artery on accident and hold pressure for 5 minutes, but it's not okay to dilate up with like a VasCath dilator into the artery. That's a big problem, and we'll have to go to the OR, okay? Line infections can happen as well, line failures. You'll get thrombosis, mechanical failures. Someone's dog will eat it or something. You can get DVTs from it. Also, ones we talk about a lot, because when you're placing a thing you're always worried about is, are they going to get a pneumothorax? Did I stick the lung? So chest x-rays for the ones up top. So there's a lot of different things that can happen, and it's important to look at them. Other things that are longer-term complications you'll see later on when patients come back in are like necrosis over their port site, or infection, things like that, scarring, and those are things you see a little bit later. So when you're looking to do it, they're going to be like, go put one in, and you're going to be like, okay, where should I put it? So look at the patient and see where you can put it. So if you see scars, there's probably been a line there before. If you see giant morbid obesity with a pannus and you're never going to get to that femoral spot, it's probably not as good spot to go. We typically always try to start with the IJ, the right IJ. That's typically our go-to one. There are, reasons you may not do that. Like I said, if there's a previous line, if you can't see a good vein on ultrasound. So I would also recommend, before you break out a kit, take the ultrasound, look where you're going to go, make sure you can go to that site, make sure you have the appropriate length of catheter so that you're not wasting, you thought you could do an IJ, but they don't have one, so now you've got to do a femoral, and that's going to take a longer central line. So also extremity trauma, think about what other things they have going off. They got busted up clavicle or scapula or something. You may not want to go on that side or up there. Also, has anybody already attempted a line before you? A lot of times surgery gets called for the difficult ones, okay? The thing that Dr. Hyde taught me is, if there are 3 other teams that could have placed this line and they're calling you, it's probably going to be difficult. So just know that somebody may have already attempted before you. Get a chest x-ray before you start. Make sure you're not the one causing the pneumo. Okay. And then also look at their coagulation profile. So their INR, how high is it? We like it to be less than 1.5, less than 2 at least. But and if it's really high, definitely tell a senior. Ask them what they want you to do. Do you want to give FFP or things of that nature to appropriately do the line? Things that we do before we place it: we do HIPAA and we do fully gown up. Prep both sides, because you don't know what's going to happen on the one side, and it's better if you can just move to the other side if you need to. Also it's important, potentially, depending on what's going on up there, it's important to have help available. Is there a nurse available? Like if they've got, a C collar on, somebody's got to hold C-spine. You don't get to rotate that head with a C2 fracture, okay? Like you've got to maintain C-spine, and you fully drape out. It's important to know what's in your kits too. I know you guys have a class, I think with Dr. Giles in Skills Lab, that'll show you what's in the kit, because each of the kits is different and they have different levels of draping, and they're typically inadequate. So I always get a large blue drape. And then placement-wise, where you want it to go, you want it to be, just where the IVC goes into the atrium there, and that's kind of the best place for it. You don't want them to be having arrhythmias or things. You will see that. It's kind of how you know you're in the heart. And then when you get the chest x-ray, you may have to pull it back a centimeter or 2, but honestly, it's better to pull it back a centimeter or 2. You can't advance it, okay? You can only pull back. Other important things to know, catheter sepsis. A lot of times people get contamination at the skin site. You'll see them come into the ER, and it's important, you get cultures from both of them real quick before you take it out. So you'll see things like this. So you remove it, you put a new catheter. You obviously, like our longer term devices, we do not put in people with infection. So like a port or a perm cath, those are when they are completely cleared for 48 hours. But some people will still need dialysis. You may have to put in a vas cath temporarily while they get over their infection. So just clean around the surface area, cut the little skin sutures, and remove the catheter. If it's a vas cath, you're going to have to hold pressure for 15 minutes. If it's a central line, 5 or 10 is okay. Make sure it's not bleeding when you stop holding pressure. If it's still bleeding, you keep holding pressure for another 15 minutes. So these are the types. Staph epi is obviously the most common since it's a skin bug, but Staph aureus is another one. Vanc is drug of choice. And then duration of therapy kind of just depends on how they respond to the antibiotics. And so then in the trauma bay, your main access is your 2 large bore IVs. That's how you can get the most fluids in the fastest. The other thing we use is a cordis, and that's 2 lumens. Again, it's because the fewer lumens it has, the faster you can push things through it. Vas cath is also a good one. That's why we use it for dialysis. And then ICU monitoring, there's a lot of different fluids and medications they're getting, so most of them need central access. A lot of them need A-lines, so you can monitor their pressures. Typically, we start radial. And then there's also Swan-Ganz catheter. I've seen this like twice. Cardiothoracic surgery does use it. You may get a phone call from the CV ICU, and you may have to see what one of those looks like and figure it out, and they'll want you to change it over a wire or something like that. So just kind of, you'll get to see that occasionally. We typically don't put them in. And then this is fun, abdominal compartment syndrome. Dresden and I were lucky enough to both get to do bedside laparotomies for this during our first year. So this is when you have pressure rising in the abdomen, and it can be due to a number of causes. But typically, bleeding is a pretty big one, and it puts so much pressure that it compresses your vena cava, your system, and then there's less blood flow back to the heart. And then they, you have to code them. They develop hypotension and tachycardia. They're having trouble breathing because all that pressure from the abdomen. They have decreased urinary output. This is when you get bladder pressures as well, greater than 20. Would indicate potential abdominal compartment syndrome there. And so it's typically diagnosed on physical exam. Their abdomen is tighter, it's larger, it's been increasing. The nurse tells you, I swear it's increasing, and you're like, okay. And so you examine them, and they're probably pretty tight, and these are the bladder pressure measurements that they can hook up to the Foley. So, and a lot of times we do fix things, and a lot of times in trauma especially, we resuscitate. We'll get in there, kind of see what's wrong, pack it off, and then it may be they need to go back to the ICU for more resuscitation and they have an open abdomen. If they do that, we obviously put a vac on it. So, if you anticipate resecting some dead bowel and going back the next day to look to see what's left, if you need to take more, you may be going back tomorrow, so that we put a wound vac on it and go back the next day. And we have the Barker vac because we have Dr. Barker. So Barker vac, you'll see these happen in the OR. It's got a 10-10 drape. It's like this little plastic drape that you cut holes in, and then you put a white towel on top of it, and you put some JP drains on it, and then you put another white towel on it, and then you put some Ioban on it. And then you make sure it's holding suction. And if it's not, you figure out where it's not holding suction. There's also the KCI wound vac system with the black sponge. These can be put on at bedside a lot of times. These are probably the ones you'll typically get asked to change. These are the ones you'll get called about in the middle of the night because it's not working or it's beeping at me. I can't make it stop beeping. beeping is a problem. So you have to go and you have to help them fix it. So troubleshooting for this, you have to find the air leak, okay? And they've got little monitors that beep and tell you the leak rate, and it's got a green section and it's got a red section, and so it tells you how much your leak is. So if you take your fingers and you try to like press down on different places and make it go into the green zone, then you found the leak. And so then you put a Tegaderm on it, okay, or some extra Ioban, or the KCI Vacs come with a lot of the plastic dressing, so you use that. So it can be helpful to do that. So that's kind of the main things we do as far as troubleshooting wound vacs. If you still just cannot get it, you can't leave it beeping there forever. You may need to call a senior to talk about what else we can possibly do for it. But sometimes it's holding good suction. You can tell it's holding good suction, but it's leaking, or it has an air leak alarm. You can set it to wall suction, but I would talk to a senior before I would do that. And that's it. Does anybody have questions? A lot of this is bedside learning too. You'll find that you see the drains and you figure out what the different ones do. You do a line with, when you're being supervised by 3s and higher to do your lines, they'll kind of talk you through their systems. And you're also going to have another class on how to place lines in chest tubes. Is that today for you guys? Interns?
No.
No, not today?
Soon. Yesterday.
Oh, it got rescheduled. Okay.
All right.
Good talk.
Your setup is half the battle. You want to have everything, you'll figure that out. But what you don't want to have is finally work, finally got your needle in vein. Now you're trying to turn around backwards to fumble around and find your wire. And by the time you do that, you've lost it. So take time to set up your system so that everything goes easily. You're not sitting here fumbling with one hand trying to do a bunch of stuff that just leads to pain and suffering. More the patient than you, for everybody.
Move the bed, ask the nurse to help me move crap around the room. Half of what I do when I get asked about the centralized for somebody is just organize the room because they're so focused on getting the line done, they don't realize that the kid's 15 feet away from them are open. They're already gowned up and have no ability to move it. Just kind of set yourself up for success. Don't pull an IR drain unless you cut the line. Bleed out like that.
Don't cut it right next to the skin.
Yeah.
In the way. You created a big problem.
And same thing for preparation for pulling chest tubes. You don't want to be that guy telling somebody to hold their breath while you go get something. Yeah, call for help. Or
You need to be doing all of these procedures for the senior resident for the next month. That's just the way it needs to be. We need to be there to help you. God, you guys. Yep. All of us. Just call us. It doesn't matter what time of day it is. Call me.
call Jay.
Doesn't matter what time of day.
Andrew McCurry got 2 of them. Good job last night. So you
Good
guys
deal.
Get them. Just they're there. Come to the trauma bay.
You don't want to be the last one to get that. You wanna
Please
be
check
the
an
first one to
X-ray
get
too. Look and see if your patient has an X-ray. If they have an X-ray before you're about to remove something, please look at said X-ray. You'll be amazed at what you'll find, like a broken catheter laying in their heart. Just saying.
If you guys are getting lines and tubes, don't forget to start tallying off on the chalkboard and keep track of that so that we know how many you've done and when it's okay to start letting you move on your own. All your names are on the chalkboard in the call room hall.
You need 10 lines and 5 chest tubes.
Does the pigtail count as a chest tube for the chalkboard? Yes. Yes. Yes.
We didn't. I don't
We
know.
didn't. We just counted like real chest tubes.
We'll have to take a consensus.
A pigtail counts more for a line.
Yeah, it's more of a line type thing. Probably real chest
We
tubes.
counted real chest tubes.
Also, entirely different.
Yeah.
If your patient does have a CT chest,
prudent to just take a look, because you'll be surprised at what you find. And sometimes, like, they already have a pneumothorax and have been sitting down in the MICU. You put your central line in, and then they have a pneumothorax on chest X-ray, and you're freaking out. But it's been there. It's stable. It's stable from all the other chest X-rays. It's not your fault.
Now it's free. It's a freebie for you.
Sometimes it's your fault.
So if you get called for a central line, you should go see the patient. You should figure out why they want it. So when you call 3 or above, be able to tell them they've constantly for a line. This is why they need it, which is something different than why they want it, or they want it or they don't need it. Figure out, you know, if they've had other lines, what their conditions are. You should be able to say, these are their platelets, these are their coax. Know those things when you call someone, the things that you didn't know before you do it. So don't call someone that ain't a line and not know anything about it. Probably because somebody's not going to have it.
Also, make sure you check if they're on any medication.
And just because they call doesn't mean they actually need one. So you do have to investigate and figure out, is it appropriate? If it's not always appropriate.
The IVT will.
Sometimes you can just put an IV in for that.
True. I don't think so. Mission, go.
If you stick one side, or you move to the other side, check an X-ray to make sure that you're not going to get what they want on both sides.
That's true.
Or don't, we talk about it on Thursday. You go to work now?
Yep.
Yes. You can go to work.
Thanks, guys.
Ready, break.
We're